Dear colleagues, as a good afternoon, dear colleagues. As a national representative of Iran, it's my pleasure to announce that the first joint webinar of European Contact Lens Society of Ophthalmologists and Iranian Society of Ophthalmology will begin in a few minutes. We have a panel of world-class experts with us, and hereby I should really thank them for their kind acceptance of our invitation. I'm especially grateful to Karina Kopen, the president, and Omar Ukakhan, the Secretary General of ECLSO. This webinar would not have taken place without their support. We are thankful to Marie-Caroline Tron, National Representative of France in ECLSO, and Shehzad Naro, the respected editor-in-chief of the British Contact Lens Association journal, Contact Lens and Anterior Eye, and global president of the International Association of Contact Lens Educators, who accepted our invitation and joined us despite their very busy schedule. Thanks also to my dear colleague, Mohammad Soleimani, who is certainly the most active corneal specialist in the emergency ward worldwide. In this webinar, we are reviewing the most important aspects of different kinds of contact lenses in summary. So let's start with the talk of dear Dr. Marie-Caroline, the National Representative of France in ECLSO on COVID-19 and contact lens via. Marie, it's to you.
Thank you. Good afternoon or good evening, everybody. My name is Marie-Caroline Tron. I work at the University Hospital of Saint-Etienne in France. I'm very happy to share this webinar with you. I would like to say thank you to the Iranian Society and the European Society for inviting me. The program of the meeting is very attractive, so I'm sure we will have a great time together. I have chosen to talk about another topic, COVID-19 and contact lens wear. So let's start. Okay. As everyone knows, we have been suffering from the global COVID-19 outbreak for the past 2 years. To date, there are many variants of the coronavirus. There are 300 million confirmed cases worldwide, and more than 5 million people have died from these infections. Several vaccines are currently available. Coronavirus can have ocular manifestations, mainly in the form of conjunctivitis. It represents about 2% infected patients. Currently, a patient presenting a fever associated with conjunctivitis is suspected of being infected by COVID-19 and must be screened. In any case, it is the rule in France, and I think in many other countries where screening tests are available. Sorry. Concerning the COVID-19 transmissions, at the beginning of the outbreak in March or April 2020, there are several unknown factors. Is there a risk of COVID-19 transmissions through tears or conjunctival secretions? Is ophthalmology a risky job? Is wearing contact lenses dangerous? All these questions have been asked 2 years ago, and conflicting advice on contact lens wear are initially given. Initial press release of American Academy of Ophthalmology recommended that contact lens wearers should switch from contact lenses to glasses. Quickly, several societies around the world, such as the European Society, for example, or the French Society, all these societies were show contact lens wearers and communicate that contact lenses are safe if hygiene rules are strictly followed. Today, we know more about the physiopathology and mechanisms involved in the coronavirus transmissions. Several studies have been conducted on this subject, and in the current state of our knowledge, there is no possibility for COVID-19 getting into the eyes through the cornea from tears. However, COVID-19 can remain on hard surface from hours to days and can be transferred to wearers' hands and faces. But does COVID-19 outbreak have an impact on contact lens wear and care? Yes, we know it does, and we will quickly see what it is. First of all, in my opinion, a distinction must be made between two periods, during and after the lockdown. During the global lockdown in March and April 2020, there was a massive discontinuation on contact lenses wear around the world. It was due to changes in people's lifestyles. Optical shops were closed and the purchase of contact lenses and lens care products was complicated and restricted to the internet. People had a reduction on their activities, work or leisure, and therefore a reduced need to wear contact lenses. The lockdown had financial repercussions for some patients, and the contact lenses purchase was no longer a priority. Finally, some patients remained suspicious on contact lenses and COVID-19. Since the end of the lockdown in spring 2020, people have started their activities again, and there is a return to contact lenses wear. Prolonged wear of masks and fog on the glasses has motivated new wearers. We also observe an increase in occasional wear. Increasing in occasional wear is due to patients alternating between glasses and contact lenses. This is a good indication for daily lenses. It avoids contact lenses care and limits infectious complications. COVID-19 outbreak has a beneficial role on contactology. New contact lens wearers are motivated, especially by fog on their glasses. It is mainly presbyopia patients who have greater processing power. Contact lenses wear is safe, but it's necessary to advise patients, especially during this time of outbreak, to limit the risk of infection complications. What advice should be given to patient and professional? First of all, hand sanitization is crucial in time of outbreak. Professionals should wash their hands before and after each contact with any patient. It's imperative that they don't touch their face after examining a patient. We're handling contact lenses. For our contact lenses insertion or removal, contact lens practitioners or patients must wash their hands with soap and water. The use of hydroalcoholic solutions should be avoided, as it may introduce alcohol into the patient's eyes and cause eye burns. Glasses should also be cleaned regularly with soap and water. As we have seen before, contact lens wear is safe if the usual hygiene rules are respected, especially concerning the contact lenses maintenance. It's important to remind patients that they must respect the recommended contact lens schedule. A daily contact lens must be changed every day. For wearers of usual lenses, they have to change daily the contact lens solutions and replace regularly storage cases. It's important to tell you about the increase of meibomian gland dysfunction, MGD, that we are seeing during the outbreak. It is responsible of the appearance or improvement of many dry eye disease, and currently there is an increase in screen time or teleworking, causing a decrease in eyelid blinking. Prolonged mask use is responsible for inflammation of the lower eyelids, reinforcing MGD. MGD leads to lipid deposits on contact lenses, and which can lead to contact lenses abandonment. This is why we have to be very careful when contact lenses fitting. MGD must be diagnosed and treated before contact lenses prescription. if a contact lens wearer has a COVID-19 infection, especially if he or she has conjunctivitis, we can advise stop contact lens wearing and get right the used contact lenses and the contact lenses storage case. Use glasses instead with regular cleaning with soap and water, and restart contact lens wearing away from the affection. In the contact lens practice, all the examination equipment in contact with the patient, as a slit lamp thickness, corneal topographer, automatic autorefractometer, must be cleaned with detergent between each patient. When contact lens fitting is performed, for example, for keratoconus, the trial set must be completely disinfected with the usual disinfection protocol. When contact lens fitting, how to choose the appropriate contact lens. I have been asked to remind you that a correct contact lens fitting combines 3 factors: safety, comfort, and good vision. For soft contact lenses, it's important to choose contact lenses with a frequent renewal and materials that are highly permeable to oxygen to avoid complications. So we choose a silicone hydrogel contact lenses whenever it's possible. Rigid glass permeable contact lenses are preferred for children, irregular or pathological corneas, or if there is significant ametropia. So in conclusion, 2 years later, COVID-19 outbreak has an impact on contact lenses wear differently according to periods. During lockdown, there was a massive decrease in contact lens wear. And after the lockdown, there is an increase in the number of new contact lenses wearers and requests for occasional wear. Thank you for your attention.
Thank you, dear Maestro, for your interesting talk. I have 2 questions for you unrelated to COVID-19, but these are frequent questions that are asked. Would you please tell us what is the lower age limit for prescribing soft contact lenses in children?
I think it depends of the age of the child. Until the age of 12 years old, aesthetic indications do not exist for children. So only functional reasons should lead to fitting a young child in contact lenses, for example, for correction of aphakia or a very strong ametropia. So in my opinion, there should not be any fitting in soft contact lenses in small children. The situation is different for teenagers because even if we prefer rigid contact lenses as much as possible, it is possible to adapt teenager in soft contact lens, especially for sport, for example. Lens care instructions must be well explained and hygiene must be scrupulous to avoid infection complication. An exception can be made for treatment of myopia progression, where soft contact lenses can be prescribed from 8 or 9 years old. In this case, the indication is therapeutic, not aesthetic.
Thank you so much. And could you please shortly explain what is the role of soft contact lenses in prevention of myopia progression, as we encounter a tsunami of myopia progression these days, and maybe COVID-19 exaggerated this tsunami?
Yeah, it's a very interesting question. Soft contact lenses for treatment of for myopia progression is designed to slow down myopic progression and limit the progression of axon length. The principle is to create the peropic defocus on peripheral retina in order to limit the growth of the eyes. Actually, there are several models on the market. For example, soft contact lens MySight for Cooper Vision or Milo for Max Novip, for example. They can be prescribed alone or in association with another treatment, such as diluted atropine eye drops, for example. They can be recommended in case of failure of optokeratology, for example, soft contact lens.
Thank you so much, Marie. I know that you have to go to the clinic and you cannot stay with us. Thank you for being with us, for presenting your interesting talk, and see you later, maybe in ECLSO meeting in Paris. Thank you.
Thank you very much.
Our next speaker is my respected friend, Professor Omur Ukakhan from Ankara University. She is the Secretary General of the ECLSO and will talk about bandaged contact lenses, ways to salvage the ocular surface. Omur, please.
Yes, thank you. And hello, everybody. Good evening. It's my pleasure to be with you today. And in the name of ECLSO, I wish to thank Fatima, Dr. Elipur, for putting this together. We are very happy to participate. Now, my talk is on ways to salvage the ocular surface whenever possible. Well, when we say bandage for the ocular surface, we mean either the contact lenses or amniotic membrane transplantation, or a combination of both. Therapeutic or bandage contact lenses are, we all know that plano-powered contact lenses used for the management of ocular surface problems or for the treatment of ocular surface diseases with no refractive purposes. They can be either soft spherical contact lenses or scleral lenses. I will be covering the soft spherical contact lenses, and I know that in her talk, Dr. Elipur will talk about therapeutic use of sclerals as well. When we say soft spherical bandage contact lenses, remember we almost always mean extended wear of these lenses. Looking at the history of these lenses dates back to 1880s. And of course, following the introduction of hydrogel contact lenses, bandage contact lens use increased in ophthalmology in 1970s. However, we are now very happy and very lucky to be able to use silicone hydrogel contact lenses since 1999 for therapeutic purposes quite safely. Why do we use bandage contact lenses? We can use them for the purpose of pain relief, for the purpose of corneal protection, for improving surface irregularities, enhancing healing as a splint to the cornea, providing hydration, or for drug delivery or to provide cosmesis. Now, if you look at these indications, you can see that for most indications, we usually use these lenses with few purposes. Say, in the case of Bell's keratopathy, we both aim pain relief and enhancing healing and protection from lashes or lid movements, improving irregularities, providing hydration. So it's like a combination in most of the cases. What are the properties of an ideal therapeutic soft contact lens? Well, we need to use these lenses on an extended wear basis, so we need high oxygen transmissibility, that is for sure. We need adequate surface hydrophilicity, wettability, deposit resistance, proper material elasticity, and proper design, of course. High oxygen transmissibility is particularly important because we know that even without contact lenses, with overnight eye closure, there's a physiological edema of about 3% in the corneas. With hydrogel contact lens use overnight, this percentage increases to about 15%. However, we know that today with silicone hydrogels, we can decrease to this edema percentage, overnight corneal edema, to almost physiological levels. And almost all, actually all contact lenses on the market, silicone hydrogels, can be used overnight for therapeutic purposes, depending on how long you need to use these lenses for the treatment of the disease. Oxygen permeability is important to prevent corneal edema, of course, but we used to see other complications with hydrogel contact lens use overnight for therapeutic purposes, such as epithelial microcysts, thinning, decreased corneal sensation, increased bacterial adherence, stromal neovascularization, or endothelial polymagatism. And we know that we are all free from these complications with the use of silicone hydrogels for therapeutic purposes. Now, I'm going to give you examples in this talk most of the time. One of the most frequent indications we use bandage contact lenses is, of course, epithelial abrasions or defects due to various reasons. In this case, we, again, aim both promotion of healing, pain relief, protection of the cornea, everything. Remember that with the use of bandage contact lenses, we have a uniform tear film layer underneath the contact lens that promotes epithelial healing, free from any trauma from lids. The epithelial defect can be due to chemical thermal injuries. It can be in the form of persistent epithelial defects due to various reasons. In this case, of course, we need to use these lenses on a long-term basis until proper epithelialization. And this can be from weeks to months, actually. For recurrent corneal erosions, again, we need to use these contact lenses for longer periods of time. We need to replace these contact lenses depending on the type of the silicone hydrogel we are using, but we may need to use these lenses for, let's say, weeks and months again before maybe we can do PTK for these cases. In the case of filamentous keratopathy, remember that bandage contact lenses provide the fastest way of healing, actually. Within 1 or 2 days, you're free from the filaments. Again, for corneal lacerations, lamellar cuts, with few purposes, these bandage contact lenses are of great help. Instead of putting stitches to the lamellar cuts, we can just put a bandage contact lens. Of course, with a close follow-up, we may end up with complete epithelialization and then healing of the cornea. With corneal perforations, again, due to various reasons, with or without adhesives, bandage contact lenses can be used for variable periods of time. Again, Dellen is a condition that we see frequently at the clinic, and we can easily heal them with bandage contact lenses. In dry eye, particularly when we need short-term relief from pain or short-term promotion of epithelial healing, we need to use bandage contact lenses and replace, say, or take it out in a few weeks. But for long periods of time, if you're talking about severe dry eye, we may switch to other contact lens types, other lens types, actually. Again, for bullous keratopathy, until we move on to keratoplasty of some sort, we need to put these patients on bandage contact lenses. With any kind of ocular surface procedures, cross-linking, topo-guided PRK and cross-linking, or any kind of refractive surgery, intacs, post-LASIK, post-PRK, in the immediate post-operative period for proper epithelialization, proper healing. We usually, at my clinic, I always use contact lenses, bandage contact lenses. And same with keratoplasties. After deep anterior lamellar keratoplasty, after PKPs, after DSEG, endothelial keratoplasty, I always use bandage contact lenses in the immediate postoperative period. For corneal protection, if we need to protect the cornea from from lid defects or scars, we need to use these lenses. Again, with vernal keratoconjunctivitis, if we have shield ulcers, they are of great help. Prosthetic contact lenses may be considered a form of therapeutic contact lens, and we know that in unsighted eyes, these contact lenses can be great relief to the patient in terms of cosmesis. Therapeutic lenses can also address low bioavailability issues or preservative toxicity or patient non-compliance issues with topical drug use, or they're very important. There are several methods that they're being studied, but unfortunately, despite these studies, there's currently still limited commercial applications of contact lenses in drug delivery due to technological limitations. But one great example is the AccuView TheraVision with ketotifen, which very recently received market approval in Canada and Japan for treatment of allergic conjunctivitis. So with a bandage contact lens on the eye, you need to continue the ongoing medical treatment. Always prefer unpreserved drops whenever possible. Always and add unpreservative teardrops to current therapy. We use prophylactic antibiotics if there are epithelial defects. And remember, always an eye care practitioner inserts and removes or replaces this sort of contact lens. It is not left to the patient to put it or remove it. So coming to amniotic membrane, it's a great adjunct in our practice. Of course, we know that it is the innermost layer of the fetal membranes. Since 1990s, we've been using amniotic membrane quite frequently in ocular surface reconstruction in ophthalmology. It has great properties. It's easily obtained. It promotes epithelialization of any sort over it. It has anti-inflammatory, anti-angiogenic, antimicrobial properties. It does not express HLA-A, B, or DR antigens. So it's a great adjunct to surface reconstruction. It can be cryopreserved or dehydrated. We all know there are various ways of using it at the clinic for either reconstruction of the corneal or conjunctival surface. Whenever we use amniotic membrane transplantation, we always use bandage contact lenses together with it in the immediate postoperative period to put everything in place to make sure the amniotic membrane is stable and the patient does not feel discomfort. This is the way we chose to practice. As you can see over here, any surface irregularities, any persistent epithelial defects that cannot be managed by bandage lenses alone, stromal thinnings or melts of any kind can be managed with amniotic membrane transplantation, maybe several layers if required, plus bandage lens use. And coming to chemical injuries in the acute phase and the immediate post-traumatic phase, we know that there is an indication of amniotic membrane transplantation. And in this case, again, we get help from bandage contact lenses. But in extensive burns or toxic epithermal necrolysis or Stevens-Johnson syndrome, again, amniotic membrane transplantation is a must in the acute phase, and with several applications, you can get great results in long term. Again, if we need to do simple limbal epithelial transplantation with limbal stem cell deficiencies for any reason, we always get help from amniotic membrane transplantation plus bandage contact lens use in the long term. With ocular surface construction in tumor surgery, again, amniotic membrane transplantation is almost a sine qua non, together, of course, with bandage lenses. So in summary, bandage contact lenses with or without amniotic membrane transplantation provide efficient bandage for the ocular surface in various applications. Unfortunately, there are very scarce RCTs on this topic. Mostly they're not well designed, with poor definition of success or failure with limited number of patients. Therefore, there is a lack of concrete evidence to prove the benefits of contact lenses and or amniotic membrane transplantation when compared to other treatment modalities. So this awaits future studies. I thank you for your attention, and I'm now stopping sharing my screen. And if you have any questions, or if the audience has any questions.
Thank you, dear Amor, for your great presentation. Any of the audience can raise hand and ask any question if they wish. We also have a panel. You can send your questions and we can ask the questions in the panel. Our next speaker is dear Karina Koppen. She's head of ophthalmology department, Antwerp University Hospital, Belgium, and president of the ECLSO. Karina, I can see you here. Is you with us?
Yeah, I'm here with
yes,
you.
yes.
I'm
Hi, Karina. How are you?
Hello, how are you? Good evening, dear colleagues. I'm starting to share my screen.
Okay, we are waiting.
Yeah. Is that okay? Everybody can see my screen?
Yeah, it's okay. We can see your screen.
Okay. Was asked you to start your video later. Okay, so good evening all. And well, Fatime, I want to start by thanking you and the colleagues behind you. As you said, there are many who have helped you for organizing this joint webinar. And the topic of my talk today is ideal RGP lenses, rigid gas permeable lenses for managing keratoconus. And I'd first like to stay a little bit longer with my title slide, because I want to explain, well, in the past, when we were speaking about RGP lenses, this automatically referred to corneal lenses. And this is no longer correct. Nowadays, the description of a lens needs to be more specific. Is it a corneal RGP lens or a scleral RGP lens? And I will briefly discuss the hybrid lenses that can also be considered RGP lenses, but with a soft skirt. So we're going to dive a little bit deeper in this topic. And for this, I will be referring to the manuscripts that my research group has published over the last 3 years. Let's see that I can make my page then. I cannot make my, yeah, there it is, it's working. Okay. Well, you all know that rigid gas permeable lenses are the mainstay for vision correction in keratoconus. And that is because they're very effective in masking the irregularity of the corneal surface. And for many decades, corneal RGP lenses have been the first choice for the visual rehabilitation of our patients. And this is because the lens and tear film can correct for all types, all amounts of astigmatism. These lenses ensure, why does this move too quickly? Ensure optimal maximal visual acuity, and the corneal RGPs are easy to handle and clean. And in contrast to refractive surgery, contact lenses can be fine-tuned to any refraction and can be adjustable if the cornea changes. And contact lens correction obviously is reversible, and especially for the corneal RGPs, we know that contact lens wear is rather safe because it has the lowest incidence of infectious keratitis of all lenses. Let's see, yeah, this works. The drawbacks are familiar to, I suppose, all of you are interested in lenses as well. These are related with discomfort and intolerance, especially for patients working in dusty surroundings. And also with fitting problems. Sometimes we cannot fit a lens very nicely, and you see 3 examples on the right-hand side. You can see a case of epithelial disruption due to central bearing of the lens. And in the second photograph, you can see a lens that is decentering inferiorly, leading to an unstable fit and increased risk of losing the lens, like you see in the fluorescent pattern of the last photograph where the lens is lifting off the cornea. And it's
excuse
now
me,
about...
Karina. Excuse me, Karina, we are still on your first slide. Are you changing your slide?
I'm changing the slides.
But we are still seeing your first slide, and it's not full screen.
I'll stop sharing.
Yeah, maybe.
Stop share, and I'll share again. Share. Is this working better? This is the title slide.
Please
It's
please make full screen your slides.
Use the full screen icon at the bottom right of the screen.
Your screen sharing. So here everything seems to work well. You don't see the slides changing?
No, we are still on your first slide.
I
think you
sharing.
should change. I think you should go to full screen icon.
PowerPoints. I'm sharing again. Is this working?
Yeah, it's working right now.
Okay, let's see if I can make the slides move then. Yeah, okay, it works.
Yeah.
Okay, so we talked about the corneal RGP lenses, and here you see that in the past 10 years, the field of contact lenses for ectasia has grown enormously. And nowadays we have lenses that can provide the excellent visual results that we were used to having from the corneal RGP lenses, but also in highly increased comfort. And this is what we call a whole range of so-called specialty lenses. And there are, on the one hand, upper left corner, okay, we have more modern designs of corneal lenses. And left below, piggyback, where you insert a soft lens under the rigid corneal lens. But I'm referring mostly to the specialty soft lenses, the hybrid lenses, and then the scleral lenses, so-called mini scleral lenses and full scleral lenses. Let's have a closer look at how in Belgium, okay, it's a small part of the world, but how we're using these different lenses in daily practice. And this is a first publication that I'd like to discuss with you, where we did a retrospective chart review of newly diagnosed keratoconus patients in 2 centers in the north of the country, Ghent and Antwerp, where I work. And this was over a 5-year period. And as you can see, we included 399 patients, mean age typical 24, 25 years old. In Western Europe, most patients are male, 3/4. And there's a lot of self-reported eye rubbing and a lot of allergies. And in the table on the table number 2 on the right-hand side, you can see the best spectacle corrected visual acuity. So when the patients presented themselves in the better eye, in the worse eye, and you can see the maximal keratometry values in the better eye, in the worse eye, and pachymetry. So you see that these patients were at least moderate, and you could even say rather advanced when they are presenting for the first time. How did we deal with this group when it comes to optical correction? Well, in 15%, we did not prescribe any optical correction. And this is a subset of patients with frosty or subclinical keratoconus in the better eye and good binocular vision without correction. I'm a strong believer in doing a very good spectacle refraction at presentation. And no file is complete without first time you need a spectacle refraction. And our optometrists pay a lot of attention to this. And if glasses provide good binocular vision, then we will prescribe glasses. I think it's now or never at that first assessment, because otherwise we're going to launch the patients towards lenses and lens dependency. And I also like the idea that contact lens wear can be alternated with spectacles, and that patients are not wearing their lenses full time from morning till evening. And under conventional corrections, you also see the conventional soft lenses, and there are a few patients who can continue with plain soft lenses if the corneal irregularity is not too pronounced. And then we come to these specialty lenses. You do see quite a lot of patients fitted with corneal RGPs, and this means that these patients were successful at the 6 months evaluation point. We took 6 months to evaluate how the patients were doing in their lenses, because 6 months allows some time. If we start with one type of lenses and it doesn't work out, then we switch to another type. But after 6 months, usually everybody's in their lenses that they will be wearing for the next years. And you see that specialty soft lenses and hybrids represent only very small groups in our patient population, and I will discuss this later on. And scleral lenses, scleral RGPs, come out as big winners because they're taking over in 10 years' time most of the field with more than 1/4 of patient fits. And table 4, it does not concern contact lens fitting, but I wanted to highlight the finding that in our cohort, only an important minority needed cross-linking. And that's a finding we might find interesting to discuss in the panel discussion. Well, it seems that we're not very successful in the use of these specialty soft contact lenses. At conferences, colleagues do speak about them, and sometimes with a lot of enthusiasm. So we did try to use these lenses. What's the trick? Well, they're generally thicker than standard soft lenses with center thicknesses ranging from 0.3 to 0.6. And this increased thickness makes a soft lens more rigid. Not an RGP lens, but more rigid. And typically these lenses can partially mask some mild to moderate irregular astigmatism. And of course, they're very good at correcting a high metropia. If you're -10 and you have a mild keratoconus, then these lenses can work for you. And that's, I would say, the same niche indication as for phakic IOLs, which some of my colleagues are implanting in Belgium. And initially, we had concerns that the thicker lenses would lead to less oxygen transmissibility, but these issues have been tackled with the silicone hydrogel materials. And it's true, they can be produced in extensive ranges of base curves, diameters, refractive powers, high cylinders. But in my hands, it doesn't seem to work. A cylinder of -6, you do the over-refraction with the spectacles, you order the lens, and then something happens, and the patient says, this is not what I experienced during the trial. And personally, I was more hopeful about a place for hybrid lenses in the correction of my patients, but you already know from my statistics that we're not so successful either. You might think that these lenses, well, they seem to offer the best of both worlds. The visual acuity of RGP corneal lenses and the comfort of a soft lens. That is how I describe them to the patient, is a soft lens with a rigid part on in the center. These modern hybrid lenses that we have nowadays, they have a high decay soft skirt, a high decay RGP core, so oxygen is no longer a problem. That's a problem of the past. Other issues that concerned us also mostly in the past, problems of fragility of the material junction. Nowadays, it's not that we don't have lens breaks, but it's much less frequent than in older designs. What I find a major problem is the issue of tightening of the lens fit during lens wear, with epithelial bearing in the landing zone leading to epithelial compression lines. We see the epithelial compression lines, and the patient who initially was comfortable drops out because of discomfort. And we tried to have a look at this in a systematic way. So we did a retrospective chart review of 102 eyes of 54 keratoconus patients. So it's not that we didn't try. And we used lenses from the USA company Synergize, but mostly the hybrid from France, the French company LCS, because we found this lens was easier to handle for the patients, easier to insert, but especially easier to remove. And in the eyes where we achieved a successful fitting, the visual outcome is generally excellent because we have the effect of the RGP central part. But our success rate at 6 months, well, only 60% of eyes pursued in hybrid lens wear. Well, we think it's a real-life clinical outcome with the main issue for dropout being lens discomfort. And on the right-hand side in that table, we illustrate the observation in our cohort that there was an association between the success rate and cone morphology. You see that the nipple cones, the purple bar, indicates success, that we had much more success in patients with nipple cones, while in oval or sagging cones with a more decentered corneal apex, we had significantly less success. We think that in the nipple and globus cones, we can have better centration and adequate movement of the lens and a better fit and better comfort of the lens. And then, well, our new workhorse, the scleral lenses, as you know, the large diameter RGP lenses, most commonly used diameter in our practice is between 15 and 17 millimeters. And if we have an ideal fit, the lens bears evenly on the conjunctival tissue and folds over the cornea with complete central and limbal clearance. And you can see on this OCT image that there is no contact at all with the corneal surface. And you might even conclude that a scleral lens is not really a contact lens anymore. We say scleral lenses, scleral contact lenses. Well, they make contact with the conjunctiva. Because they clear the cornea, they do a better job when it comes to respecting corneal integrity. You see that this patient, this example in the OCT, it's an advanced case. You see the thinning, the deformation, and actually you see a superficial scar. And the scarring occurs naturally as the cone progresses. But in corneal contact lens wear, I'm sure that in some of my patients, these contact lenses have contributed to the scar formation. And this will not happen in scleral lens wear. And the fact that the interaction with the corneal nerve plexus and also with the eyelids is eliminated, it contributes to a highly increased comfort for the lens wearers. And in a publication from 2020, Shorter et al., they described that scleral lens wearers do report greater satisfaction, so that it's not just feeling, an intuitive feeling, but an evidence-based fact that patients are more satisfied with comfort, but also with vision compared to corneal lens wear. Now, we also did a prospective study in our center looking at patients' reported outcomes. And we looked at 89 eyes of 50 keratoconus patients who filled out a questionnaire before starting with scleral lens wear and 6 months after lens fitting. And you can see the excellent clinical outcomes with significant improvement of both visual acuity and vision-related quality of life. And I want to highlight some details. It's a visual improvement in the better seeing eye that correlates with vision-related quality of life. And the visual improvement in a worse seeing eye, that was something we did not expect. We were not looking for this, but it's correlated with improvement of near activities. I indicated that we fit a lot of spectacles and we say, well, if binocular vision is okay, then you don't need contact lens fitting. But this made us reconsider and explain to the patient, well, if you are experiencing problems with reading, it might make a significant difference if we do fit that worse seeing eye. Well, not everything's perfect in the world of scleral lenses either, though. The main reason for dropout in 22% of our patients is lens handling, and we're in the middle of the results that are reported in literature. And this was not a surprise. We see lens dropout more often in unilateral fits, in patients in whom only the worst seeing eye needs a lens fit and the other eye has this frusta or subclinical keratoconus. And another of our publications concerns the fact that, well, scleral lenses have helped us to reduce the number of keratoplasties that we have to do. Now we see this in reports that come from over the whole world, that we're doing less and less transplants for ectasia. And we have to thank corneal cross-linking, but also scleral lenses. It's sometimes forgotten. Sometimes there's too much emphasis on cross-linking, leading to less corneal transplants, but scleral lenses are helping there as well. And that's the reason why we wrote this report. The scleral lenses help us reduce the need for keratoplasties. We had a look at a database of 846 patients diagnosed with keratoconus over a 5-year period. And we selected the really severe cases. It was a little bit subjective to define this as a Kmax over 70, but the reviewers accepted this as a definition of really severe. So scleral lens fitting was proposed to 75 eyes that were included in this study. 3 eyes proved to be intolerant to lenses because of allergy, and you can say you can treat allergy, you can't treat it in very severe allergies, so sometimes you can't just make allergy go away. 9 eyes did not have lenses fitted because of good visual acuity in the other eye, where the patient says, yeah, I have an enormous difference, but it doesn't bother me. Okay. 3 eyes were successful with corneal or hybrid lens wear, not very typical, a typical result, but it worked. And of the severe cases, 9 eyes proceeded to transplant surgery, and you can read the reasons below. So this means from the 75 eyes that we fitted 51 eyes with scleral lenses. And they made a huge improvement in visual acuity, the mean gain in visual acuity, lenses versus spectacles. Okay, that's not surprising. In this group of severe keratoconus was 0.5 in Snellen. What was the result? Well, of the 51 eyes, in the long term, we saw that in 40 eyes, lens wear was very successful. We had a very long follow-up, a mean follow-up of 30 months. So not just 6 months, really, I would say mid-term, long-term. 40 out of 51 eyes were successful in long-term scleral lens wear. I call it long-term. And what happened to the other 11? Well, 7 were lost to follow-up, and 4 were unable to handle the lenses. So again, handling the lenses is a major issue with scleral lenses. And what was the conclusion of our report that was published in AGO? Well, that without scleral lenses, we would have had to do a keratoplasty in more than double the normal number of patients in our center. You will see, well, 2% of our population over a 5-year period, that's a low number. 4% is even a low number. That's well below the 10 to 20% that you typically find in the literature. But then I must admit that our center is a little bit biased. We've been fitting lenses, putting a lot of emphasis on fitting lenses for as long as possible in severe keratoconus, because as contact lens specialists, we know that if you have a keratoplasty, well, chances are that you will not escape refitting with contact lenses to treat post-keratoplasty astigmatism. So we've always been very strong in fitting lenses as long as it was possible. And this brings me to my conclusion about specialty rigid gas permeable lenses in a keratoconus clinic. And when I'm looking back with you at this group of patients that present the new patients in your clinic. At first presentation, well, in our clinic, we saw that a majority of patients, more than 60%, needs contact lens correction for vision improvement. And this typically is RGP, either the corneal lenses or the scleral lenses. And the corneal lenses, even though we're big supporters of scleral lenses, they remain a very relevant way of optical correction because they're relatively easy to handle. They're small, almost everybody can learn to handle a corneal lens. And not to forget, they're cheaper. The soft lenses, the hybrid lenses have a very limited application, early cones, preferably central cones, and they are actually relatively expensive. And the scleral RGP lenses are preferred in the majority of cases because they offer this excellent visual acuity in combination with a stable and comfortable lens fit. So in Belgium, I can speak for my country, scleral lenses have replaced the corneal lenses as a first choice for irregular corneas. And perhaps this is a matter for discussion. I might have concluded by saying, well, the scleral lenses have become the new gold standard. The truth is more nuanced than that. You still see, even in my center, a lot of corneal lenses in Belgium, still a lot of corneal lenses. So to say that scleral lenses are the gold standard, we have these patients that cannot handle scleral lenses well. So the ideal RGP lens does not exist yet. So with these words, I would like to thank you for your attention and again draw the attention to our conference of the ECLSO in Paris. Beginning of September, we hope, because it's the end of summer, that COVID will have gone forever or give us a break and allow us to meet each other in Paris. Thank you.
Thank you, dear Corneal, for your comprehensive talk. Actually, you reviewed all kind of contact lenses for managing keratoconus patients. I really thank you. And so may I ask the speakers to turn on their webcam so we can start panel discussion. Omur, Maria, if you are still with us, Mohammed, you can turn on your webcam too. Omar, one of the audience asked you a question in the chat box regarding the choosing contact lenses for dry eye. Would you please explain it for all of the audience?
Yeah, I thank for the question again. In the case of dry eyes, we usually fit soft bandage contact lenses whenever we have significant epithelial irregularity or filamentous keratopathy that disturbs the patient and also the vision. So in these cases, we try to limit the duration of bandage contact lens wear to at most few weeks under close control to make sure we do not, lead to keratitis, and we are scared of infectious keratitis. But in cases, typically these cases are usually Sjogren's syndrome patients, rheumatoid arthritis, secondary primary Sjogren's syndrome patients with relatively severe dry eyes. But in cases where we need where we need further healing, despite full treatment, if we cannot manage to keep these patients symptom-free or the surface, regular, then we switch to scleral lenses. And in the long run, if we need contact lenses for long term, then it is usually not a contact lens, but a scleral lens that we prefer. We fit the patients with scleral lenses, teach them how to use it, and then follow these patients.
And may I ask you, in acute Stevens-Johnson syndrome, when you prefer, for example, a patient with persistent epithelial defect, when you think that you should change from soft bandage contact lenses to scleral lenses?
Now, in the acute phase, you cannot fit the patient with scleral lenses. These patients can, like the toxic epidermal necrolysis patient I showed you, the child, she was in intensive care unit. So in these cases, in the immediate post-traumatic period or with the acute phase, what we do is usually we prefer to do amniotic membrane transplantation, and it is an indication for burns as well, So we put an amniotic membrane and change it accordingly, redo amniotic membrane transplantation as needed as soon as the membrane resolves, and follow these patients until complete, if possible, epithelialization. But whenever the patient is, the conjunctiva is healed, there are no symbliform formation, there's no fibrosis, then we start fitting these patients with scleral lenses, not in the very acute phase.
So you are not pro using scleral lenses for treating persistent epithelial defect?
No, I didn't say that actually. For acute toxic epidermal necrolysis or Stevens-Johnson syndrome, that is our approach. Okay. Otherwise, yeah, you can do scleral lenses. Like we have several neurotrophic keratopathy patients that we follow for years with scleral lenses with persistent epithelial defects.
Thank you so much. Karina, what is your approach to KCM patient that claims he has tried RGP and could not tolerate it?
I didn't understand the question completely. Can you repeat it?
What is your approach to a KCM patient who claims that he has tried RGP and could not tolerate? You know that many ophthalmologists say that patients are RGP intolerant, and this is a very common phrase that we hear every day from corneal specialists who want to proceed to DALK or corneal inlays. They say that patients said, I'm RGP intolerant. What's your approach to these patients?
Yeah, that's a very good question. And it's good that you say, well, is a patient, it's a doctor who says contact lens intolerant, because all these publications on refractive surgery for keratoconus, they start by saying, yeah, all my patients were contact lens intolerant. Okay. Obviously, at congresses, one of my main, when I'm talking about scleral lenses, I often stress the fact, well, it depends on the audience. I don't know if the whole audience here is contact lens, contact lens specialists, or if there are refractive surgeons.
There are optometrists and ophthalmologists, you know, many corneal subspecialists in our audience.
Yeah, to the refractive surgeons, I would like to say, well, if you're not fitting contact lens yourself or in your practice, make sure that the patient has had a scleral lens trial. Because if patients are telling you, I'm intolerant to corneal RGP lenses, then I'm not going to discuss too much with the patients. Is this really true? Can we have another try? If the patients, and sometimes they don't even know if they tried corneal or scleral ones. They will just tell me, I've tried rigid lenses. And I tell them, were they small or were they big? Were they moving or were they very stable on your eye? And if they had done a trial with corneal lenses and they said, I was so unhappy, I tried for several weeks, because if they say, well, I tried for one day, then I will tell them, you should give them a chance for several weeks and try to grow accustomed to them. But typically, these patients will tell you, I've tried it, I don't want to go back to that. If they haven't tried scleral lenses, I will tell them, you have to try scleral lenses. And even if they're refusing this, I will tell them, give it one try. Please, 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 do this for me. And they will have a scleral lens on their eye and they will say, okay, this is something completely different. It's stable, it doesn't hurt me. I could work with this. Okay, we still have the ones that will drop out because of the handling. But there again, I insist very strongly. Sometimes patients come and they say, I've tried scleral lenses and it didn't work for me. If they're keratoconus patients, I will tell them, we'll go over the whole drill again. You will get extra teaching. Because sometimes my colleagues in other centers, they don't give enough attention and time to teach the patient how to handle the lenses. And then I will send them to my optometrist who can spend half an hour, 1 hour, and we'll say we will go over it again. And I'm really, I'm not easily convinced that somebody is scleral lens, contact lens intolerant, because if they go to refractive surgery, just this morning, I had a patient, he has intracorneal segments in one eye and an ICL in the other eye. He had cross-linking and he's wearing 2 scleral lenses. So, and he's still complaining about, so I didn't put in all the hardware. He came with the scleral lenses and he was now becoming intolerant to the scleral lenses because he was using pilocarpine. And he was using pilocarpine because the rings, the segments were so close to the pupil that he was so unhappy about visual quality. Okay, he was using pilocarpine, developed follicular conjunctivitis, had to stop pilocarpine, can't stop pilocarpine, and today we've decided we're going to remove the segments. So I do everything possible in the world to make lenses work for patients. because for keratoconus patients, the alternative is not so attractive. The refractive surgery doesn't really work well for those who need it most. The mild cases, yeah, okay, it can work, but there are soft contact lens can work as well. And the more advanced cases, well, if they move on to DALC and PK, I tell them, well, if you're saying to me that you're intolerant for lenses, beware, because at the end of the DALC or PK adventure, there's a high risk that you will need this type of lens again. So please, 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 dear patients, give it a try before we're going to surgery, and convince me that you're really intolerant. And their allergies and dry eyes are my worst enemies, because this is objective intolerance. But then these are also not nice cases for surgery. So excuse me for giving you a very long answer.
No,
but I hope
Yeah, we enjoyed it because, as you say, it's a very usual phrase at the beginning of every refractive surgery paper, doing some procedure on keratoconus eyes. Let's ask a question from Mohammed. Mohammed, as a corneal subspecialist, when you refer a patient with severe ocular surface disease, such as chemical burn or Stevens-Johnson or TIN, to contact lens clinic? We cannot hear you, Mohammed.
Yeah, can you hear me?
Yeah.
Yeah, excuse me. Actually, in the acute phase, I usually use a contact lens. I mean, a therapeutic contact lens for persistent epithelial defect or ocular surface compromisation. But in the last stage, when I am using contact lens for optical purpose, I will do that when the ocular surface is stable, and then I refer the patient to the ocular surface clinic. But in the acute phase, I usually use therapeutic contact lens. But it's my own question that sometimes in this patient the patient has tarsorrhaphy or blepharophy, and the epithelial lesion will not improve for more than 1 month. So how long can we actually reserve the contact lens on the ocular surface? Because when you remove the contact lens in this situation, putting it again is so difficult.
Yeah, Omar, do you want to answer this?
Oh yeah. Now, if I could understand properly, now if we anticipate that we need to put the contact lens or keep the contact lens on the eye for long periods of time, then I always prefer high DKT silicone hydrogels that are FDA approved for monthly wear, extended wear. So I put these contact lenses. I hate to remove them early because of the reasons you have already stated. With each removal, you put the epithelium into more trouble and danger and prevents epithelialization. So what I do is I follow the patient and change or replace the contact lens monthly.
Mohammed, many cases with tarsorrhaphy has been referred to me for fitting scleral lenses. I should say that as the parameters of scleral lens will change after opening the tarsorrhaphy, so I may ask the ocular surface surgeon to open the tarsorrhaphy for a week and manage patient with bandaged contact lenses, and then refer her to me for fitting a scleral lens in order to get right parameters. I have a experience with a patient who I tried to fit her under tarsorrhaphy, and after receiving her lenses and opening tarsorrhaphy, the lens was not good for her eyes. So it's really important to fit scleral lenses while the eye is in the state that is going to continue on this state. If you are not supposed to open tarsorrhaphy completely, okay, it's okay. But if you wish to open the tarsorrhaphy, you should do it before fitting a scleral lens.
Actually, my question was that how long you can how long the contact lens will remain for therapeutic purpose in the ocular surface patient when they have a tarsorrhaphy or bilirubin, because when you remove the contact lens because of the existence of tarsorrhaphy or bilirubin, putting again the therapeutic contact lens is so difficult.
Yeah.
I usually I usually reserve the contact lens for more than 2 months, but under topical antibiotic. But I don't know what's your idea.
Honestly, with acute burns or acute chemical injuries, I do not do tarsorrhaphies. I do amniotic membrane transplantation and redo it as needed with conformers, and use bandage contact lenses as well whenever possible. So you can do temporary tarsorrhaphies. I do temporary tarsorrhaphy. I never do permanent tarsorrhaphies. Temporary tarsorrhaphy to me is just one stitch that can be easily opened and closed. So that is not a problem in my practice. But I would not keep any kind of silicone hydrogel contact lens more than 1 month on the eye. Definitely, I would replace it.
Yeah, thank you.
Okay, so if you want to stick to the actually program, we have to go to the second part of the webinar. And the first speaker in the second part of the webinar is myself. And I'm going to present Okay. I'm going to present a short talk on scleral contact lenses and their optical and therapeutic indications. Okay. When we say scleral lens, we should define what do we mean by scleral lens. Based on the international nomenclature recommended by the Scleral Lens Education Society, those lenses that rest entirely on the sclera are called the scleral lenses. And if they are up to 6 millimeters larger than horizontal visible iris diameter, they are called mini sclerals. And if they are larger than it, they are called larger sclerals, or previously called full sclerals. Most specialty lens experts prefer to use scleral lenses in cases RGPs fails, as Karna said, although there is a trend to use scleral lenses as a first option in scleral lens practitioners, but still most experts prefer to use scleral lenses for those cases in them corneal RGPs fails. For example, in advanced corneal ectasia, which cannot be fitted with corneal RGP, or those cases, as Karina showed beautifully in her slide, who develop corneal scars. For example, you imagine a patient who has been satisfied with his corneal RGP for 10 years, and now he comes to you and complains of decreased vision, and you find a corneal scar on the apex of the cone. It's not unusual. We all know that epithelium is thinnest on the apex of the cone and is prone to develop a corneal scar, and it may be aggravated by 3-point touch fitting of corneal RGPs. And in these cases, we may wish to change to a safer lens, such as sclerals. Some patients are dissatisfied with their corneal RGPs because of frequent popping out, or because of incomplete vision resulting from residual corneal astigmatism. Fluctuation of vision is also another concern in corneal RGPs, because as we know, corneal RGPs moves a little bit more than scleral large-piece. And these are situations that scleral lenses can be a good choice, because as we all know, scleral lens evolved all through the cornea, and so has the capacity of simulating less corneal sensation and corneal scar, keeping cornea transparent, and causing little or no corneal distortion. And correcting much higher amount of astigmatism. I remember a case of one eye patient suffering from advanced KCN, and his cornea was completely vascularized due to severe VKC, and had almost 25 diopter of irregular astigmatism, and he could be fitted with scleral lenses and achieve 20/25 vision. Miraculous. Better centration is also another advantage of scleral contact lenses. We have shown that even pediatric age group as young as 4 can take advantage of these kind of lenses, either therapeutic or optical, as you can see in this slide, or 2 kids, patients of mine, one suffering from advanced KCN, a paraplegic boy, and the other a 9-year-old girl suffering from high irregular astigmatism after corneal keratoplasty. But fitting and handling of these lenses is completely different from corneal large-piece, and this is an issue for those practitioners and patients who used to use corneal large-piece. And the learning curve is a little bit steep, as the tear turnover behind of these lenses is almost negligible. The lens should be filled with saline and insert on the eye while the eye is kept parallel to the floor to avoid the spilling of the saline. And this fluid reservoir, this thick fluid reservoir beneath the lens is the part that actually neutralizes any amount of corneal astigmatism resulting from any irregularity rooting from any part of the cornea. The number of practitioners that fit scleral lenses has increased dramatically during the past decade. Karina, you remember that maybe 6 years ago when you asked the audience in the UCLS conference, how many of you fit scleral lenses, there were only a few hands raised. But in the last UCLS meeting, more than half of the audience raised their hands as they started to fit scleral lenses. The most common indication for fitting scleral lenses is corneal irregularity, and ocular surface problem is another main indication of fitting scleral lenses. Let's have a short review of the anatomy of the limbus and sclera. The scleral shape has a great variation in general population. Scleral shape, corneal scleral angle, limbal angle, and it's not even different in different people. It's almost different in semi-meridians of even one patient, and this make fitting a scleral lens a little bit challenging. Unfortunately, it cannot be assessed by routine instruments in most ophthalmology clinics. You see how the range of the variation is high. Recently, some instrument for assessing scleral shape has been proposed and are now commercially available. These are either anterior segment optical coherence tomography or topographic imaging, and more importantly, Fourier transform profilometry. With use of these actually instruments, we can assess the shape of the sclera and even actually order customized scleral lenses. But as I said, unfortunately, these instruments are not easily accessible in most ophthalmology clinics. And so we have to try trial lenses and rely on them and order the lens parameters based on the actual characteristic of the trial lens on patients' eyes. Most scleral lens labs let us to ask for some modification the shape of the lens besides sagittal depth, which is the most important parameter of the scleral lens. we can change the mid-peripheral curvature to achieve better fetal limbus, and we can ask for flatter lens edge to decrease conjunctival impingement. And we also are able to ask for back surface toric for achieving better fit in those patients who have toric scleral shape. And we also can ask for front surface toric scleral lenses to actually neutralize residual astigmatism, either lenticular or residual corneal astigmatism. More customized lenses, such as creating a notch or quadrant specific alterations, is also possible with some kind of scleral lenses. Let's get back to optical indication and review some cases together. The most common indication of using scleral lenses is corneal ectasia, keratoconus, and there are lots of reports in the literature that shows that scleral lenses are safe and effective in managing even very advanced cases of ectasia, as Karina showed in her lecture too. Some patients, some keratoconic patients are referred to us after interventions, which were supposed to actually correct vision of patients, but were unsuccessful, and patients is dissatisfied with his vision. For example, after corneal inlay, it's not unusual, and we showed in a manuscript that we can manage these unsatisfied patients with scleral lenses. This is one of these cases. He was complaining of monocular diplopia, and he had a large amount of both lower and higher aberrations, and could be managed successfully with the scleral lenses. And these post-keratoplasty patients, you see that the resulting astigmatism is so high, maybe higher than the beginning. And this case may be plausive marginal degeneration with eccentric corneal graft, very high amount of astigmatism, almost 8 diopter, and he also could be managed with the scleral lens and achieve 9/10 visual acuity. RK patients are not as lucky as keratoconic patients due to other bothersome optical phenomena such as striatal scattering and more irregular posterior cornea, but still in up to 60% of RK patients, we can achieve good optical results, such as this case, but they are more unpredictable. We also have shown that the scleral lenses can be used in patients with aphakia and severe concomitant ocular injuries, such as aniridia or dense corneal scar. Look at this 8-year-old kid with total aniridia, aphakia, and a very dense and a big corneal scar. Miraculously, he could achieve 7/10 visual acuity with the scleral lenses. Or this 8-year-old girl, which is now 18, she was managed by a lensectomy, pupilloplasty, aphakic artisan implantation, and rotational corneal graft, yet achieved 2/10 visual acuity, and she could be managed with the scleral lens and gain 8/10 visual acuity, and she is with us for more than 8 years, for more than 10 years, actually. Let's review therapeutic indications of scleral lenses, as Omar referred to in her talk. Scleral contact lenses can help ocular surface diseases by providing a constant fluid reservoir over the cornea, which prevents it from getting dried. And scleral lenses can also act like a shield and can protect cornea from getting robbed by the keratinized lid margin or getting traumatized by trichiosis or dystichiosis. So when we put scleral lenses in on these patients' eye, they report immediate relief of pain and photophobia. And we may even break the vicious circle of inflammation by actually keeping the ocular surface calm. And they also gain vision by neutralizing corneal irregularity resulting from dryness and corneal scar. This lady was suffering from filamentary keratitis. This is not the picture of her at the presentation. It's almost 3 months after starting scleral lenses. She was suffering from severe filamentary keratitis and was disabled. And she could return back to work after using scleral lenses. And after 6 months, she was filament free. And now maybe it's more than 5 years that she's with us. And she wear her lens only for addressing her actually dryness and decreasing need to frequent lubrication. The filaments didn't recur back. Or this young engineer, he was suffering from low vision after chemical burn. And fortunately, he could get back to work after 2 years and is doing so for more than 8 years thanks to his scleral lenses. Or many cases of Stevens-Johnson syndrome and graft versus host disease, TEN, and other ocular surface diseases, as Omar referred to and as we reported previously in journals. So we can have close collaboration with oculoplastic ocular surface clinic and help them managing their difficult patients in subacute stages of the disease, decreasing need to tarsorrhaphy and invasive interventions like this, and managing their difficult to manage patients. And we also need their help for addressing issues that cause a suboptimal fit, such as symbol furrow, cicatricial changes in the eyelids, or furnaces, or elevated conjunctival scar, which result in suboptimal fit. And in a close collaboration, we can come to good results. Another group of patients which may be referred for scleral lens fitting is patients with glaucoma. There's no consensus in the literature about the effect of scleral lenses on the IOP homeostasis, and also there is no consensus regarding how to measure IOP in scleral lens users. But fortunately, there are some evidence that shows that there are minimal effect on IOP homeostasis in normal eyes, and normal adult eyes are capable of tolerating IOP stress for long term. But we are actually worried about those patients who are susceptible to baropathic effect of the scleral lenses, as these lenses may alter venous drainage system and alter aqueous outflow and cause IOP spikes. So we should be concerned about it and actually do our best to measure IOP. There are some ways for suggested for measuring IOP, for example, measuring IOP immediately after removing a scleral lens, or using corneal calibrated device against the conjunctival tissue, or using transpalpebral tonometer through the eyelids, but none of them are sure accurate. At least we can document optic health by, for example, RNFL CT, or documenting it in each follow-up visit. Those glaucomatous patients who had history of trabeculectomy are more difficult to be fitted with scleral lenses because of the deformed conjunctiva and risk of compression of the filtering bleb and altering aqueous outflow, and also risk of neovascularization and risk of bleb-related infection may be increased. Shunt patients are less challenging. At least there are some reports in the literature that they could be fitted successfully, although I was not brave enough to do it in any patient with shunt. Less adverse effect and problem of fitting is actually is encountering in these patients. But tube compression and tube erosion are issues that we are concerned about. Despite this miraculous effect of scleral lenses that Karina and I said, and I showed you in some cases, these lenses are not complications or obstacle-free. They are more expensive than RGP lenses, as Karina said. They are almost 10 times more expensive than RGP. They have to be fitted and ordered only in a few certified clinics, as I said, because of the scleral shape. The learning curve of this fitting the scleral lenses is steep. So not any contact lens practitioner is capable of fitting scleral lenses. The fitting is more time consuming, and these lenses are more difficult to handle. As Karina said, it's the most common reason for a dropout of these patients. The complications that are reported with scleral lenses are most commonly midday fogging and conjunctival injection. These are relatively common complications. Infective and non-infective complications are not so common, but has been reported. Corneal hypoxia is an issue which we are worried about, and fitting issues and handling issues, as I said, are actually our daily challenges. So my take-home message is, before considering surgery for your patients, or when you are disappointed from providing good vision or eye protection for your patients, think about scleral contact lenses. Thank you for listening. Okay. So our next speaker is Shehzad Naro. He is the, as I said before, he is the editor-in-chief of the prestigious Journal of Contact Lens and Anterior Eye, and he is the global president of the International Association of Contact Lens Educators. Shehzad, thank you for joining us, and I really appreciate your kind acceptance of our invitation. So let's go to hybrid lenses and listen to Shehzad.
Dr. Alipur, thank you very much for the kind introduction, and it was a pleasure to listen to you speak. We've never met, but we've had many email correspondences, so I hope in the future, when travel is open again, we can meet in person. It's a pleasure to be here. Thank you for this kind invitation. Let me just do a share screen. So, okay, I'm hoping that you can see my slides. I'm going to move to the slide presentation now. Okay, so I'm going to talk a little bit about hybrid lenses, but I'm going to talk generally about specialty contact lens practice just to kick off with. And as Dr. Alipur very kindly said, that I'm based at Aston University in the United Kingdom, and we are one of the optometry schools here. In fact, we are the largest optometry school in the UK. So my work experience is largely academic and research. I haven't been in practice for many years, but I'm involved in contact lens research and teaching as well. I just stepped down last year as the president of the International Association of Contact Lens Educators, and I'm also the editor of the journal Contact Lens and Anterior Eye, which is the journal of the BCLA, the British Contact Lens Association, which some of you may be aware of. Okay, so let's just kick off with a thought about specialty contact lenses. And I sometimes have this debate with myself and sometimes with other people about specialty contact lenses. You know, what are specialty contact lenses? Do they really exist? Is it the contact lenses that become special? Is it the practitioner that becomes special? Or is this just some marketing term that we've invented to say that something is special and therefore we can charge more for that product, or we can charge more for the services by the people who offer that product? Well, regardless of what we think of that term, it is the fastest growing sector of the contact lens market. When we look at all the prescribing trends around the world, we see that contact lenses for the specialty lenses, like scleral lenses, are growing very, very quickly. And there are indications for specialist contact lenses. We don't really think of cosmetic colored lenses as specialist lenses, but they could be used in a specialist application, which I'll show you in a second. And in some parts of the world, they are sold in fashion shops. I've seen them being sold in machines in railway stations and things like that. I was on an aeroplane once, and I saw in the in-flight magazine that you could actually buy colored contact lenses from on the aeroplane, you know, in the duty free. And really, I think we'd all agree that even plano cosmetic colored lenses should be fitted by a qualified practitioner. Now, when we think of specialist lenses, the first one that we always think of is keratoconus. And then we start to think about those post-surgical patients, maybe refractive surgery, maybe corneal graft, maybe things like keratoplasty or lamellar keratoplasty. There's other irregular corneas, there's keratoglobus patients or pellucid marginals or scars, aphakic patients, and other prosthetic uses and other therapeutic uses. And the therapeutic element is actually growing. We have a current research project in my university where we're looking at drug delivery in contact lenses, for example. So that area is growing all the time. And what are the advantages of using these specialist lenses? Well, it's really when the visual acuity with the specs is not adequate, and with a conventional lens, contact lens, it's quite poor still. And usually this is related to a high order aberration. And so the specialist lenses can try to give us better image quality to reduce those higher order aberrations. And sometimes it's actually the conventional lens, the fitting isn't quite right. So we need a specialist lens, maybe a custom made lens based on the topography that can improve the fit as well. And then, as I mentioned, there are some cases where we think about masking a pathology or cosmetic. And this is one example of that. And this is a patient who has a coloboma. You can see that the inferior part of the iris is missing. And in this type of patient, you could give them a painted soft lens with an artificial pupil and an opaque surround, so that you create an artificial pupil for this individual, and that would improve their image quality. Similarly, if you had a patient with aniridia with no iris, again, you may want to give them that artificial pupil and give them a painted soft lens or something like that. But other cases could be following some sort of surgery, some sort of trauma to mask a scar, or even to hide atropia. Now, I wanted to tell you about this survey that myself and my research group, we did. And we actually did this in February 2020, and it's just in the process of being published now. Actually, it's just been accepted for publication. And this was done just pre-pandemic in the UK. The lockdown in the UK happened in March 2020. And we devised a questionnaire, and this was actually based on the questionnaire that came out of Manchester Eurolens research. Many of you will know Professor Philip Morgan, and he does an annual survey of contact lens prescribing, and he does a survey in the UK, and then he does a bigger survey internationally. And we kind of followed that template, and we sent out questionnaires to hospital eye service clinics and asked them to give us information about their last 10 contact lens fits. And the people took the questionnaire away, they sent it back to the research team. And we gave the questionnaire to 12 different hospitals in our region, and only one of the hospitals didn't return the questionnaire. So we had a completion rate of 92%. One of the hospitals gave the information from only 9 fits rather than 10. I think they just made a mistake. So the data that we analyzed was from 109 contact lens fits. And interestingly, we had in this group of 109 fits, slightly more males than females. Now, when you compare this to conventional contact lens wearers, we often say that in conventional contact lens wearers, it's more females than males. And most studies show it's almost double the amount of females. So the ratio is often 2 to 1 in favor of females. When we look at conventional contact lenses, the average ages of patients who wear contact lenses tend to be sort of in the 20s. They tend to be 25 to 30, that sort of age group, the sort of high-end 20s. And in this study, they were about 39. We had 2 who were aged 1 year or less. And so if we remove those 2, then the average age, the mean age went up to about just over 40 for the cohort that we looked at. The wearing time, most of these patients who use specialist lenses are wearing these lenses all the time, and they're wearing them nearly every day of the week, about 10, 11 hours a day. And in our study, we had 5 patients who were wearing extended wear contact lenses, and those were bandage lenses actually. And if we exclude those 5, then the wearing time just comes down slightly, but not much actually. But this is the interesting information, I think. So of our 109 patients, 61% were being fitted with specialist lenses for keratoconus. Then the next big group were refractive patients, and those were about 8%. Then aphakics, about 7%. Post-graft was about 6%. Other cosmetic issues was around 6% as well. And then the other primary corneal ectasias like pellucid marginal degeneration, around 3%. Cross-linking, 3%. Bandage lenses, 2%. Pseudophakia, 1%. Aniridia, 1%. Blepharospasm, about 1%. And then secondary corneal ectasias were also about 1%. Now, we look at the types of lenses that these patients were wearing. The majority, 57%, were wearing corneal rigid gas permeable lenses. And then the second biggest group, 26%, were wearing soft lenses. And then scleral and mini sclerals, 7% and 5%. We've just been hearing about those. Piggybacking, about 3%. And the hybrid lenses was only a very small fraction, about 2%. And that was the smallest group in the study. Now, when we look at the 61% who were wearing lenses for keratoconus, and that was 70 patients, of those, 69% were wearing corneal gas permeable lenses, which I suppose is what we'd expect. And then around 10% were wearing scleral or mini scleral, 4% piggyback, 3% hybrid. And then I think this was something which we found quite interesting, was that 14% of the keratoconic patients were wearing soft lenses. Now, bear in mind, in the UK system, keratoconic patients can get their contact lenses from high street practitioners, from routine practice, but the moderate and advanced cases will certainly go to the hospitalized service. So these were more the moderate and the high-end advanced keratoconic cases. But again, around 1 in 7 were being fitted with soft lenses. So whilst most of the keratoconics were being fitted with rigid gas permeables, like I say, 1 in 7 were wearing soft lenses. And then the mini sclerals and the sclerals was about 10% of the patients and 12% overall. Now, those hybrid lenses that I talked about was actually a very small percentage, and only 2% overall and 3% of the keratoconics wearing hybrid lenses. And if anyone's used hybrid lenses, what is a hybrid lens? Essentially, it's a soft peripheral part to the contact lens and then a rigid gas permeable center. Now, remember that we often are fitting these lenses to patients who have something like keratoconus, and they may have higher corneal sensitivity, and they may be people who are atopic and maybe rubbing their eyes and things like that. So sometimes when we give them a gas permeable lens, a corneal lens, it doesn't feel so comfortable for them. So sometimes we will piggyback, but hybrid is another alternative to that, where we have the soft peripheral skirt. So the comfort is improved by the soft skirt. And then the optics are improved because we have the gas permeable element in the center of the contact lens. And this is one example of that lens. This is a lens made by a company called Synergize, and this is the clear cone lens. And this one has a HEMA type skirt with a low water content, only 27%. And the skirt, the soft element, can be fitted steep, medium, or flat. And the central corneal element, the gas permeable element, can be fitted according to the corneal curvature. Now, one of the complicated things with these lenses is that essentially they're soft and gas permeable in one lens. So how do we clean them? Now, this one is a HEMA-based lens. So this one can be cleaned with a hydrogen peroxide system. And the hydrogen peroxide is adequate to clean the gas permeable element too. So that's the clear cone lens. And like I said, that's got a low decay skirt and the high decay central element. And we can also nowadays have the sort of the modern version of this. And this is the Ultra Health lens, also by Synergize. It's another lens that they make. And this is a high decay center and a high decay skirt. But the high decay skirt in this case is from a silicon hydrogel material. So that gives us higher oxygen permeability. And if we compare the gas permeable characteristics of these two lenses, you can see that the Ultra Health lens has an oxygen permeability of about 130 versus 100 with the clear cone lens. And the newer lens also has the UV blocker inside the lens as well. If we look at the soft skirt, which I think is probably the more important element here, we can see that the water content is actually quite similar, 27% on 32%, but the Ultra Health lens is a silicone hydrogel. So obviously the water content will be less. And in fact, that one has a oxygen permeability of around 84, which is obviously a much better lens for that periphery, especially in a compromised cornea. Ooh, there's a slide missing there. Sorry, there's a slide missing where I wanted to show you a picture of the vaulting. But when we fit these lenses, we also fit them in a very similar way to scleral lenses. So the patient goes into a supine position and holds the lens almost in a tripod on their fingers, or they can use the plungers and they put the lens in from underneath. And so the fitting can also be done with sodium fluorescein. So we use some sort of fluorescein in there. Now we usually use a high molecular weight fluorescein, something like fluorexon, because that will not get into the soft lens element of the contact lens. So that's something which can help us to fit. And typically we want these to vault around 100 microns above the cornea. So we start with a vault of around 250 microns, and then the lens will set a little bit. So it's very similar in terms of the application of the lens and the way that we fit the lenses to scleral lenses. But here's an alternative that we try to get a little bit of comfort because it has that soft skirt. Thank you very much.
Thank you, dear Dr. Naru, for your informative and interesting talk. We enjoyed it a lot. Thank you. And we also use your prestigious journal a lot for actually, hopefully for publicating our papers or reading interesting papers in the contact lens on anterior eye, which is by far the most prestigious contact lens journal. Thank you. So our last speaker is my dear colleague, Dr. Mohammed Soleimani. He is by far the most active corneal subspecialist in the emergency field, I think, in the world. Mohammed will present a talk about contact lens related emergency visits. Dr. Soleimani, would you please share your screen?
Hello. Can you see my screen?
Yes, but it's not full screen.
Yeah, just a moment. Hello, and how are you? And many thanks for your invitation in your well-organized webinar. Yeah, the screen is good. Actually, first of all, there is no financial or any proprietary interest in our product, in method or material described here. But I gotta speak regarding contact lens emergencies problem, and there are an estimated 140 million contact lens wearers during in the world, and contact lens associated complications are common, and more than a third of contact lens user in a survey actually said that they had some medical advice for complication during contact lens using. So contact lens problem and complication may be common, but what is the reason of this complication? What is the reason of this complication and this visit? There are some changes during contact lens user. Actually, one of them is increasing dendritic cells in the cornea that and increase or activation of the dendritic cell. As you know, when the dendritic cell are increased, the corneal subbasal nerve would be decreased, so the corneal sensitivity would be decreased in contact lens, where on the other hand, microvascular conjunctival alteration will actually started, and pro-inflammatory process of ocular surface would be seen in this patient. On the other hand, we have some kind of dry eye because contact lens using, and the reason may be some change in blinking and decrease in lipid layer of the tear meniscus. The other problem that we should actually pay attention is contact lens prescribing in diabetic patient. We must carefully consider the duration of diabetes and the level of glycemic control, and even the presence of retinopathy. And so when we are prescribing contact lens in this diabetic patient, it's so important to actually pay attention to the diabetic control and general health of the patient. The other fact is that people who wear contact lens should have a complete eye examination at least once a year, and it's recommended for patients to have a backup pair of glasses during the use of contact lens. However, what is the emergency problem related to contact lens wear? The first and most important of them are corneal infection, and the other items are mechanical problems, including corneal abrasion, metabolic complication, and toxic and inflammatory reaction, and dry eye. There is a symptom. There is a sign regarding contact lens. We say contact lens induce acute red eye response. That usually we see this complication in extended wear contact lens user, and it may be actually start by the toxin of Pseudomonas or Haemophilus influenza or exotoxin of gram-positive bacteria. And the other reason may be tight lens or upper respiratory tract, actually, and especially using with Haemophilus influenza, such as this guy with actually contact lens or related red eye syndrome. As you see, we have conjunctival injection, and sometimes we may have corneal edema related to steep lens, actually tight lens syndrome. The other problem is corneal infiltration that may arise from infectious or non-infectious inflammatory etiologies, and risk factors for corneal actually infection are included young age, hygienic control of the patient, and lens material and wear modality of the contact lens. So regarding the corneal infiltration, the first item is peripheral corneal infiltration, or peripheral corneal ulcer. Circular epithelial lesion associated with corneal stromal infiltration could be seen in this situation, and the microbial antigen is the most culprit of this situation, typically from gram-positive bacteria, and the most important microorganism is Staphylococcus aureus. This is one of our patients that had a ring infiltration with some somehow epithelial defect on it. Actually, she was referred because of suspicious acanthoma keratitis. But the difference is that the central part of the cornea is clear, and we have a very mild conjunctival injection, and also in the confocal scanning, we don't have any cysts, and instead we have a lot of Langerhans cells in the stromal part of the cornea. So actually the patient was managed according to peripheral corneal ulcer related to contact lens using, and the topical steroid and mild topical antibiotic was used, where we use topical antibiotic and topical steroid, and the corneal infiltration was under control with a mild corneal scar at the end of the follow-up. The other problem that we can see in this patient is conjunctival papillary reaction or conjunctivitis or papillary conjunctivitis. The use of soft lenses is particularly silicone hydrogel has been proposed as a significant risk factor for this situation. As you see in the middle image, we can divide the palpebral part of actually the palpebral part of the conjunctiva to 5 segments, and the middle segment is usually involved in papillary conjunctivitis in this patient. If segment 2 and 3 are involved, and we may have a local papillary conjunctivitis, and if the olar parts and the most actually and especially the middle part and nasal part are involved, we may have generalized papillary conjunctivitis. All of them are important to manage, and we usually use muscle stabilizer and topical antihistamine and steroid for managing this patient. And also the important point is discontinuing the contact lens and change to daily wear actually program. The most important complication is infectious keratitis. As a matter of fact, we encounter an 80 time increase in infectious keratitis when we are using contact lens, and the incidence of infectious keratitis is about 2 to 5 per 10,000 lens wearer. So the risk factors are important. The risk factors are actually very important. Poor storage and poor hygiene and extended wear. Please pay attention that the extended wear contact lens have a risk of 10 to 15 time for increasing corneal infection. Overnight wear could increase the risk to 8 times. And smoking and internet and mail order are very important. Internet and mail order are actually in the risk of contact lens induced corneal infection, and the other obvious risk is cosmetic contact lens use. The important fact is that all of the corneal infection after contact lens are not necessarily pseudomonas or acanthomonas keratitis. This is a patient with fungal keratitis after contact lens use, but and also actually she was progress in the actually corneal infiltration. There was a progress in corneal infiltration, and so she need a keratoplasty, and you see that during the keratoplasty we had corneal infiltration going into the AC. Actually, it's very important to manage this patient in early process. The other problem is lens binding. And sometimes we have a very rare problem that is embedded lens. Sometimes contact lens may be embedded in the superior fornix and can result in the formation of foreign body granuloma or cystic lesion. Or in this patient, as you see, it mimic actually an orbital mass, and so it is important to actually to have this problem in our mind. The other problem is corneal abrasion, such as this patient, that and the corneal abrasion may be induced during rubbing or actually because of foreign bodies trapped between the lens and corneal surface. The other problem is superior epithelial actually arcuate lesion. We sometimes have limbar or paralimbal corneal lesion located in the superior part of the cornea, and this is likely due to forces applied by the upper eyelid and creating shear forces between the contact lens and the corneal surface. And at the end, we have a long list of metabolic complications, including limbal redness, epithelial staining, and also stromal edema, endothelial dysfunction, and corneal exhaustion syndrome. This is actually this is a syndrome that may be induced by corneal edema and conjunctival injection, and the contact lens use will not tolerated by the patient. And this is a case that case of acanthoba keratitis. You see in the A part, the patient has some epithelial irregularity and also then pseudodendritic lesion. The patient was actually managed as a herpetic keratitis, and after that fungal keratitis. When she referred to us, she had this actually feature in her corneal surface and severe pain in her eyes. So we started a confocal scanning, and in the confocal scanning there were too many C's, so anti-acanthoba therapeutic regimen was started, including PHMB and chlorhexidine. And in the part B, you see that the keratitis was under control. However, the patient during actually a loss of follow-up progressed to the part C, and you see a large corneal ulcer. So we did a corneal graft for the patient, but the fact in this patient was that she was an uncontrolled diabetic patient without any retinopathy. She was 19-year-old, but she had actually uncontrolled diabetic retinopathy, diabetic situation. However, unfortunately, after a keratoplasty, she had a relapse in acanthoba keratitis, and also she has acanthoba endophthalmitis. So she underwent again a keratoplasty with conjunctival flap, and this is the final feature of this eye. And in this part, I brought some sections of confocal scanning, and as you see, we have targets Cs in this confocal scanning. Yeah, this part. This is the last patient that we had with bilateral acanthoba keratitis because of cosmetic contact lens, and the bilateral acanthoba keratitis was uncontrolled. So we did keratoplasty with a period of 1 month between each of them, and finally both eyes had clear cornea. And this is the section of pathological section of the cornea that is full of acanthoba keys, and this is a beautiful section that shows double wall Cs. As a take-home message, we should actually know that pseudodendritic lesion in contact lens user is very important, and acanthoba keratitis can easily be missed in this patient. And every red eye in contact lens user should be visited carefully, and it's very important to manage. Thank you.
Thank you, Mohammed, for sharing these horrible cases with us. Actually,
yeah,
we have to become more cautious. You have told me that very few of your cases are those patients that are managed in our contact lens clinic. So this shows that, as you said, those patients that use their contact lens, which are ordered from internet or actually buy their contact lenses from optic shops or miscellaneous routes, they are more prone to develop complications. And most of your patients are those that are not being managed by any special contact lens practitioner.
Yeah.
Thank you. So may I ask the speakers to actually turn on their webcam? We want to start our second panel. So dear Karina, dear Umur, dear Shehzad, Mohammed, would you please turn on your webcam and we can start our second panel. Thank you all. Okay, I have a question from you, Shehzad. In a patient with regular astigmatism, when do you recommend hybrid lenses?
Oh, that's a good question. For regular astigmatism, I would recommend hybrid lenses if the cornea was compromised. So if there was something that I was worried about on the cornea or I couldn't get the fit right, then it would be something I would think about. But typically, we're managing more irregular astigmatism with this type of lens. But Dr. Alipour, while I'm speaking, can I just quickly show those two slides that I missed them out from my presentation? I can very quickly show those because there's quite a nice picture of the lens that I wanted to show. So very quickly, sorry about this. Okay, so this is the picture I wanted to show you of the when you put the high molecular weight fluorescein in the hybrid lens, and you can see in the one picture on the on your right, this is a keratoconic picture, and you can see there is a little bit of apical touch as well, some bearing. And on the other picture, you can see a lot of pooling. And the other picture was when the lens first went in. It's actually the same eye when the lens first went in, and then it will settle a little bit. So the sag is reduced with a little bit of time. And that's very similar to the way that we fit a scleral lens. And this is the, a nice fitting lens, but this is looking at the skirt of the lens. You can see the skirt, it's quite a big lens. This is a 14.5mm lens. And then this is just the other picture I wanted to show you, was the way we insert the lens. So you can use the little rubber inserters or the tripod method on your fingers and balance the lens on your fingers. And in this silicon hydrogel material, we generally don't use peroxide, but we would use a multi-purpose solution. So thank you for that. So for that opportunity to share those.
As you said, we expected that hybrid lenses be as comfortable as soft lenses and give us crispy vision as hard lenses, but they didn't act like this in the clinic. And in my experience, clear contact lens, which with a low decay skirt, was more comfortable than Ultra Health. That was new generation. Actually, I had to turn back to clear cone for some patients that I decided to continue hybrid lenses. Do you agree with me?
I do agree, because although we know it has a lot of shortcomings, hemo is a very comfortable material to wear. So, we know about the oxygen is not great in hemo, but it's a comfortable material. And some silicone hydrogel materials, the surface properties can sometimes give a little bit of discomfort. And these are eyes which are already compromised and already sensitive. So sometimes, yes, you're right, we need to revert to a different product.
Thank you. And do you recommend hybrids for patients with history of corneal inlay or graft?
Oh, well, that's a good question. I've never fitted one to a patient with a history of inlays or graft, but for graft, I would be probably more tempted to fit them with a mini scleral or a scleral lens, if I'm honest, and I wouldn't really fit a hybrid. For the inlays, did you say?
Yeah, corneal inlays such as intacts or
something like that. I think it depends why we're fitting them. If the intact has decentered, then maybe we're not going to get a good fit with a hybrid lens. So we may need to again go to a scleral lens where we vault the cornea. But if it was just for a visual settlement rather than a decentered intact, then yes, you could fit them with a hybrid.
Yeah, I was myself worried about the health of the cornea, just above the ring, the actually transition zone of the hybrid lens may actually superimpose just over that vulnerable part of the cornea. So I myself prefer scleral lenses over hybrid lenses in these patients.
I would have to agree with you. I mean, you asked me if it could be done, and I think, yes, you can do it. My preference would be in those cases to fit a scleral lens or a mini scleral. So it's often when, you know, if I'm worried, if I don't want to put any weight on the cornea, which is in a lot of these cases, then I will move to a mini scleral or a scleral lens.
Okay, thank you so much. Mohammed, what is the most common misbehavior in patients with contact lens related keratitis?
To be honest, I have several misbehavior in these patients, and the most common behavior may be actually, for example, not to have a good hygiene during contact lens using. Yeah, and some of them actually are addicted. I don't know. I'm not sure that what is the most common behavior.
Yeah.
Yeah.
Yeah, there are a few cases you have told me that wore their contact lenses for a year and forget about it. You extracted a discolored contact lenses from the eyes of these patients.
Actually,
I think,
brown contact lens.
yeah. Yeah. And which complications have you seen with aphakic RGPs? You know, the most common pediatric group that we actually prescribe contact lenses for them are aphakic children, and we prescribe aphakic RGP, and parents are worried about the potential complications of aphakic RGP. Have you ever encountered any specific contact lens related complication in these children?
Yeah, to be honest, I didn't have any actually serious complication where in these children wearing hard contact lens. I think that because of good management in your contact lens clinic, and I don't remember any serious complication in these patients, other than, for example, missing RGP or other problems.
Thank you.
Yeah,
Thank you. We
like that.
sometimes the most reported complication in these categories of patients, as we have seen, is acute red eye, which may be due to trapped particle behind the RGP, or maybe epithelial damage while inserting the lens. And this could be easily managed by lubrication and topical antibiotic for
but these
1 or 2 days.
these are not serious complication. Yeah.
Okay, thank you. Thank you so much. And dear everyone, what is your practice regarding one eye patients? Karina, do you prescribe lenses for one eye patients?
Well, you have to get it right each time, even in patients with two eyes. I apply this also for surgery. You want to get it right for every eye, one-eyed or two-eyed patients. If they need lenses, we go for it. Of course, we're not talking then about -3 patients. There, I would say, if you have a -3, then I wouldn't go for lenses. I'm going to say something, a curse. Well, I'd rather recommend the patient to have refractive surgery for -3 than wear a contact lens.
Yeah.
I'm a contact lens specialist, not a refractive surgeon.
Omar, do you prescribe lenses for one eye patients?
Yeah, I would. I think there should be a medical indication. Like, you know, as Karina has already said, say it's both, I mean, two-eyed, normal, regular patient. If there is a contraindication for contact lens wear, then I would not prescribe. Like dry eyes, say, moderate dry eyes, unless very mild, you know, I would not. So, or MGDs or whatever. I mean, I would treat as two-eyed regular patients, but I would not prescribe, you know, for any reason, for like say mild myopia, I would not refer them to refractive surgery either, Karina. I'm sorry.
Yeah.
Considering they may need cataract surgery in the future.
Yeah, it's contraindication, absolute contraindication of refractive surgery. One eye patients should not undergo refractive surgery,
goes
and they
well, you know,
may even get some advantage of using protective eyeglasses for protecting their eyes from trauma. They are more prone to trauma. And so to sum up, we do not prescribe contact lenses for actually elective indications, such as correcting refractive errors in one eye patients, but for therapeutic indications, we are prescribing contact lenses, but are more concerned about managing potential risk factors for developing complications. So another question, what is your choice for optical correction of an aphakic 4-year-old child actually suffering from aphakia and corneal irregularity and has still sutures on his cornea? You know, many of ophthalmologists ask us when to refer post-traumatic patients for contact lens fitting. I said 4-year-old because we are still worried about amblyopia, and these are a group of patients, a group of pediatric patients that are prone to develop traumatic corneal scar. And it's a common question that I'm frequently asked for that, when to fit these kids. A traumatic case, having suture on cornea. Any idea? Mohammed, when do you refer them to us?
Yeah. Well, yeah, to me, there is not any contraindication for using contact lens in these patients, because if you don't prescribe contact RGP for this patient, amblyopia will be actually in the situation. So I think that there is not any contraindication, and as you know, we refer this patient to your contact lens clinic for contact lens fitting.
Shahzad, do you have any idea about the optimum actually time for fitting post-traumatic corneal irregularity?
What type of lens did you say, or what, or when?
Actually, we need corneal RGPs because the cornea is very irregular in these kind of patients.
Yeah, but you said the cornea would also have sutures in as well, so
yeah.
And so
the
that
patient
would...
is not suture free because it's still 1 month after trauma.
Yeah,
and there are still sutures on.
Yeah, I mean, again, it depends on the position of the sutures and things like that. So, you know, whether we're going to look for a large diameter corneal lens, or maybe would we have to move to a mini scleral and have the 4-year-old child's parents involved in the removal of the lenses, because, you know, obviously the child cannot do that.
So, Karina, do you have any idea?
Well, if the eye is quiet, you might be interested to correct the aphakia as quickly as possible. And you might even consider fitting a soft lens. I know we're all into rigid gas permeables for children, but as a temporary measure, I never mind using both types of lenses, rigid gas permeables and soft lenses, because at a specific time, one might have advantages over the other. It's like, well, I don't like continuous wear, nobody does. But you can leave a soft lens on. Well, you can do continuous wear of a rigid lens as well. They do a lot of that in France. But I must say, I don't have that experience of continuous wear rigid lenses. So as you've already noticed, I dare to go beyond the line sometimes. And I would see if the eye is quiet, if a soft lens, continuous wear to correct for aphakia might have an indication. Fitting the rigid lens, well, everything's possible, but babies are easier to handle than 4-year-olds. So
Yeah.
fitting a rigid lens is can also be a big challenge.
Yeah. Yeah, as our hospital is a referral hospital, and we see lots of these cases in those children that have a corneal edema and very actually bad situation, we prefer to wait until get a better situation to fit. And during this time, we may correct aphakia either with actually unilateral eyeglasses just for patching time, for part-time patching time to prevent amblyopia, because the main problem is aphakia here, not corneal irregularity. And but after a while,
Why
we
don't
changed to
the
RGP.
secondary IL implantation? You said traumatic patient, aphakic 4-year-old, you can just go on with surgery, you know?
Yeah,
Secondary
but
IL
you know, these
implantation,
traumatic patients, we have very few surgical options. We cannot use a scleral fixation, and because of the actually half-life of the propylene sutures, and we cannot use artisan. Aphakic artisan is not FDA approved. We have very little options. Actually, in the acute phase, we may change to it after a while as a secondary IOL implantation. But in the actually first phase, the children may be left aphakic for a while. And during this period, we have to manage it. I myself do not have any concern with sutures, but if the sutures are actually resulting in deformed cornea and corneal edema and some issues that may actually cause potential complications or intolerance, we may wait a little bit to get a better situation and then start to fit patients. But the sutures themselves are not contraindication of fitting RGPs.
Yeah, as you know, if the suture are not in a good situation, or we have severe corneal irregularity, so the aphakia is not actually our most important concern. The most important concern in this situation is corneal edema, or for example, handling sutures. So we can actually accept these cases from our situation.
Yeah, we may have to wait for a while and wait until the situation get better, and then go to actually use amblyopia plan for treatment. And everyone, have you ever encountered corneal decompensation as a result of a scleral lens-induced hypoxia? You know, there is a large concern about the decreased DK over T of scleral contact lenses due to thick tear lens behind it. But I myself have never encountered any case of scleral lens-induced hypoxia. I have sometimes some cases that they had partial corneal decompensation resulting from trauma and fitted with the scleral lenses, and this decompensation was not aggravated and even actually subsided with time. So as this concern is very hot topic in the literature during these last years, have you ever encountered any case of corneal decompensation in scleral lens users?
I have once.
Once.
That was a patient who had PKP years ago. I don't remember how many years, but years ago. And the graft had limited reserve. Because of some reason, I don't remember, I said we can try to the patient, asking him to come to close follow-ups. And yeah, I did see decompensation, but easily could reverse the graft, just took the scleral lens off, and he discontinued lens use. And yeah, we could save the graft. But I have seen, and I think it might happen in grafts with limited reserve.
Yeah, thank you. and we showed in a paper that endothelial polymycotism was not increased by using scleral lenses, and surprisingly, it was more in those patients who used the corneal RGPs. We didn't actually anticipate it, but it was so. So is there any other question from the audience? Okay, so I should say that the panel is closed right now. And thank you again for participating in this wonderful webinar. We enjoyed a lot of your informative and interesting talks. And thank you, the audience, for staying with us until this time. So I should say goodbye. Any other point?
No. Thank you for your great presentation and your great organization for this webinar, actually. Yeah.
Thank you so
Thank
much.
you, Fatima.
Yeah, thank you.
Thank you.
Bye.
I agree. Thank you.
Bye.
Night.
Bye.
Bye, Troll. Bye.
Bye.